The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with Inside JACC, and I'm talking to Dr. Paul Chan. And Dr. Chan is assistant professor of medicine at the University of Missouri at Kansas City, and he's on the staff of the Mid-America Heart Institute. He's the first author of a really interesting paper in JACC that deals with the appropriate use criteria for coronary revascularization, and specifically what kind of agreement exists between the recommendations of the technical panel that put together these appropriate use criteria and the general practice population. They took the appropriate use criteria recommendations prior to publication and tested them on a group of about 80 physicians, 80 cardiologists in 10 different practices. Now, the indications for individual clinical scenarios were either appropriate, uncertain, or inappropriate. And interestingly, what they found that overall there was an over 80% concordance between the practicing community and the technical panel. However, while the concordance was quite good for appropriate recommendations, once one got to the inappropriate recommendations, there was only a 70% concordance. Moreover, nearly 70% of physicians would disagree for at least one category. So it showed that general agreement, but some considerable areas where practicing physicians felt differently. So, Paul, let me ask you, first of all, why is it that this disagreement existed? Was it a fact that the data were not conclusive as to whether revascularization should be done or not, or that the practicing community just was unfamiliar with the actual data?
I think it's a little bit of both. Certainly for the indications that are known to be appropriate, it's guided by a lot of the clinical practice guidelines and clinical trials. And for those indications that were adjudicated as appropriate by the technical panel, there was a lower non-agreement rate. That is, the rate of non-agreement where more than 1 out of 4 physicians rated a clinical scenario as different from the technical panel was only 44% of the time. However, for indications that were inappropriate and adjudicated as inappropriate by the technical panel, we found that non-agreement rates were 70%, such that in 7 out of 10 scenarios that we evaluated as inappropriate, more than 1 in 4 physicians rated the indication as uncertain or appropriate. So there seems to be a difficulty in the translation of the clinical practice guidelines in understanding when procedures are appropriate or inappropriate. We also know from the Dartmouth Atlas for procedures such as for PCI that there has been huge variations in utilization rates, and this may partially explain some of the differences that we see regionally across the Dartmouth Atlas.
Given the lack of concordance that exists, would you say that these guidelines really are sufficiently well honed that they can act as a basis for quality assurance, or are they really suggestions as to the best way to practice?
The appropriate use criteria were developed based on clinical practice guidelines and clinical trials, as well as expert opinion. There are certainly areas where there is still a gray zone. For example, a number of indications are rated as uncertain, and so the clinical benefits of percutaneous coronary intervention for those procedures remain yet to be determined. And it may be possible that there is a clinical survival gain benefit or clinical health status benefit for these patients. Certainly for clinical indications that are adjudicated as appropriate or inappropriate, there is greater strength of evidence to support or not support the use of PCI in those scenarios. And I think that the use of the appropriate use criteria for those types of procedures seems very reasonable to help support a rational and judicious use of a very limited amount of resources in our healthcare system.
Based upon the results of this study, it's clear that some disagreement exists among physicians as to the best way to go about practicing coronary revascularization. So there's clearly an important role for clinical judgment in individual patients. We'll have to hone and refine these appropriate use criteria in the future so there's nearly universal agreement. For Inside JACC, I'm Tony DeMaria.